You're listening to Parallax from Radcliffe Cardiology in association with makeadent.org. Here is your host, Ankur Kalra, MD.
Hello, everyone. Welcome to another episode of Parallax. My guest on the show today literally needs no introduction. She has been on Parallax before. She actually has been a feature for this segment of Parallax in that she eloquently summarizes the trials which have been presented at the European Society of Cardiology Congress. She was there in person this year in London, and I was living vicariously through her posts on X, where she was gracious enough to tag me and share all the evolving science which was being presented in London. So without much further ado, my guest on the show today is Dr. Purvi Parwani. She's a dear friend of mine. She is a cardiologist extraordinaire. As we all know, she is Associate Professor of Medicine at Loma University Health. She is now the director of the Echocardiography Laboratory at Loma University Health. And we know that she has had a role as being the director of women's health. So with that introduction, Purvi, thank you so much for doing this for us, and welcome back on Parallax.
Thank you, Ankur. So glad to be back, and thank you for that kind introduction. I'm always happy to be, doing this segment for Parallax because it also kind of, gets me going and gets me, a chance to further dive deep into these trials that we are going to be discussing today.
Yes, absolutely. So Purvi has done a fantastic job in picking some of the incredible structural heart disease trials that were presented at ESC this year. So Purvi, we're going to start talking with the list that you've picked for us, and the first one on the list is Matterhorn, which is transcatheter edge-to-edge repair in comparison with surgery for patients with secondary mitral regurgitation. Do you want to talk to us about Matterhorn?
Yeah. I think before we start doing the trials, I think I wanted to just tell you, structural space is expanding so much, right? And why I picked these trials is because, the echocardiographic evaluation of whether it is mitral regurgitation or tricuspid regurgitation, now has a different meaning. So I think for the first time, I feel like as diagnosticians, structural imagers are forefront of all of this. So, of course, this interests me because there can be so much implication, on the diagnosis part, in addition to how we are tackling the problem. So, to be honest with you, all the mitral stuff really got me excited. There is a tricuspid trial that we are going to discuss as well. So, as you mentioned, Matterhorn is transcatheter versus surgical mitral valve repair in the secondary MR. Here, what was the unique feature is that this is, the first time they are comparing MitraClip with surgical mitral repair in this high-risk population, which is heart failure and secondary MR. So they picked 210 high-risk surgical patients. I think 40% were women, secondary MR. Ejection fraction here was around, mean ejection fraction was around 43%. So not your sick heart failure patient, but rather kind of in that moderate range. Their mean left end diastolic diameter was 61 mm. So meaningly a little dilated LV. And then, the mean EROA, the orifice area for the mitral regurgitation was 0.22 centimeters square. And why this is important is because when you look at those numbers, this is not the patient population that previous trials have selected. This is more kind of, secondary MR, the EROA of 0.22, so not 0.4, which is by guidelines considered as severe MR. 51% of these patients had AFib. And that's again relevant because, as we all know, secondary MR is a very dynamic process, Ankur. Depending on what diuretics patients are getting and what day they come to the lab, your assessment may be completely different. And we see this, in clinical setting. I think they also selected the patients that were hospitalized for heart failure at least twice in the year prior. So they wanted to see how that kind of comorbidity with mitral regurgitation and heart failure can be reduced because these patients were hospitalized for heart failure. Now, as you know, GDMT has evolved quite a bit, and having these patients on good GDMT before you do any of these device therapies is so essential because the first pillar in the heart failure treatment, as you would agree with me, is GDMT. So, I think I think 70% of the patients were on ACE or ARB, 84% were on beta blocker, but then MRA was only 26%. And we don't know, what SGLT2 inhibitors they were on. We don't know what diuretics they were on. So that was the patient population that we are looking at. Now, of course, patients were randomized to mitral clip or surgery, and 72% of them underwent mitral valve repair, and 28% of them underwent mitral valve replacement. So I want to stop there and kind of see what you have thoughts on this, this population, demographics.
Yes, no. First off, excellent preamble to the discussion, Purvi. I agree with you that echocardiography has become a fulcrum for structural heart interventions, and I think as even as an interventionalist who did a formal year of training in structural heart disease after my coronary year, and who sees these patients in valve clinic, I have to keep up with my echocardiography skills. The reason I signed up for maintenance of certification in echocardiography, I want to keep up with at least the diagnostic skill set in transthoracic as well as in transesophageal echocardiography, is because with the advent of technological advances in structural heart interventions, diagnosing these valvular lesions accurately has become crucial. So I couldn't agree with you more that you have to be up to speed with how you categorize these lesions. And then to your comment on, secondary MR. Now, this is, we see these patients very commonly. This is sort of bread and butter cardiology. A lot of these patients, like you mentioned, your mean ejection fraction is 43%, which is not terribly low. And then your effective regurgitant orifice area is 0.22. So it's not that it's like 0.4 like we used to have for primary MR. This is secondary MR, so it's a little different. So, as we are discussing this, the message for the listenership and for the cardiology audience is that you have these patients all over the place in your clinics, in the hospital wards, and these are your quote unquote stable heart failure patients. And these are patients who, now I think we have become, as a field, fairly good at trying to initiate, although some of the recent papers I've seen on implementation of GDMT when it comes to quadruple backbone, the rates are still abysmal. And in part, that is because of financial toxicity of these drugs and how difficult it is to get prior authorization on some of these medications. But I think the initial intention for the cardiologist to start patients on these medications is fairly high, in my opinion. So I think in that space, to have a trial like this, certainly, kudos to the investigators for doing this. Again, something which I want to reiterate on what you said, really important point, that is the first time a transcatheter technique is being compared with surgery, which has been the gold standard for mitral regurgitation. We did a retrospective analysis looking at the same question, from the readmission database from the Agency for Healthcare Research and Quality. And, some of the findings which we published are similar to what you're going to tell us about this trial. But, that's sort of how I see this trial. So I think, again, thank you for picking this up. This is very important. We see these patients all the time. That's my synthesis on when I saw the selection criteria and the baseline characteristics for these patients for this trial.
No, thanks for giving that summary. I always am curious on, how as a structural interventionist, you all perceive those things that you just discussed about. So I think, in simple words, if we look at the conclusion of this trial, that, of course, MitraClip was effective. It was a non-inferiority trial. And, compared to surgical mitral valve repair, MitraClip met the non-inferiority with clinical efficacy. It had better safety profile. And, the conclusion, of course, is for symptomatic secondary severe MR, it's a safe option. Now, if we kind of look deep into like the nitty-gritty of this trial, you see that they just had 1 year follow-up. Now, you being involved with this procedure and me being involved as an interventional echo person, that of course is not enough follow-up, right? Because we know that a lot of these patients have dilated LV, secondary MR, even if the ERO is not that much with that dilated LV, the how long that clip is gonna be effective in holding that MR always remain a question, at least in my mind when I'm looking at those patients. So, 1 year follow-up in my mind is not it's a limited follow-up. And more importantly, if we look at the 5-year co-op data, we know that secondary MR is the disease of the ventricle, and it's not the disease that is of mitral valve itself, right? So if we look at the 5-year co-op data, almost like, I think 3/4 of the patients either died or they had already been hospitalized for heart failure at 5 years. So, it just asks you, you have to ask a fundamental question. If we take secondary MR, which is a super dynamic process, we have to ensure really good GDMT. Again, one of the criticism, if you look at this trial, where is the GDMT arm? We don't know. Do we really need to do anything? And, we are going to discuss this reshape HF. So we'll have some of this discussion. But I think that at this point, with this advanced GDMT, not to include a medical therapy arm is truly a limitation, in my opinion, although, I absolutely believe in CLIP and rightly selected patients. So I think as a clinician, what I see is that, I agree with you. Our intentions are always to get these patients on, optimal GDMT. And I really, truly agree with you that, even for a community cardiologist, we all understand the importance of GDMT. But then we do see these really low rates of GDMT application. So in that, all of this data, I think the first thing as a cardiologist, our responsibility is to make sure that these secondary MR patients get as much benefit from all the GDMT. Hopefully they don't, hopefully they can get the medicine and they don't have much side effect. And then, second thing is that, we really have to carefully select these patients and see who will benefit from this procedure. Joanne Chikwe she was the discussant for this trial, and she did a fantastic job of kind of presenting the side as a surgeon. Because here, quality of surgery was also quite, variable. I told you the replacement versus repair. A lot of patients got replacement, and to her that was, not acceptable. As we know, repair is done in selected centers, so it's not, good mitral repair centers are still hard to find. So that is something that we have to keep in mind. And I do think that if I have to select between the two, these patients are sicker, I'd probably lean towards MITRA clip, although the jury is still out there, given the limitation of this trial.
Yes, no, I agree with you. At my former organization, we had an excellent mitral valve repair surgeon. And these centers, these surgeons at these specialized centers are not ubiquitous, like you mentioned. So I do think that that's a limitation. And, I think it's kind of surprising that they published this without disclosing background guideline-directed medical therapy. So I agree that's an important limitation of the study. And, in all disclaimer, currently in my practice, I'm not a MitraClip operator. I'm screening these patients for transcatheter edge-to-edge repair. Certainly when I was training, I was trained in MitraClip during my structural heart fellowship. But, in all disclaimer, and to keep myself honest, I understand the literature and, I certainly understand the science, but I'm truly not a clip operator at the moment. Now that may change in the future, but I just wanted to, maintain, full disclosure and honesty here. I'm only limited to the aortic valve and, all comers PC as an interventionalist. So great discussion, Purvi. Thank you for this. So we can move to the next one, which I think is a continuum of the same theme that you've picked for us with mitral interventions. And that is, I think, an important question as well, which is, again, mitral transcatheter edge-to-edge repair, this time with a background of maximally tolerated guideline-directed medical therapy. So do you want to talk to us about ReShape?
Yeah.
HF2 trial?
Yes, absolutely. So I think ReShape HF2, of course, is the third important trial in this space for functional MR. When we compare GDMT versus mitral edge-to-edge repair. And I think probably back in the day, I think this trial has had really delayed, kind of presentation. It's getting published at 8 years, so it saw that ugly face of challenges with COVID, etc. So I think at least when it was designed, probably it was designed because we have MITRA FR that we know was in Europe, and it did not find any differences in all-cause death and heart failure hospitalization. And then we had co-opt from United States, North America, Canada. And we all know co-op data that, clip repair, it was associated with, again, not only just heart failure hospitalization, but it also improved mortality in 2 years. So there was this conflicting data, and maybe that's why this trial back in the day was designed. Now, in the interim, of course, we all know that here in United States, we have we do TEER for secondary MR patients, particularly when they have persistent symptoms after they are being treated with GDMT. And I think in guidelines, it's a class 2A indication, both for US as well as Europe. So I think it's important to understand the trial, how this patient population is different from MITRA FR and co-opt, and why we think that MITRA FR and co-opt had the conflicting results, so that we can understand what exactly this trial can offer us in context of those two trials. So I think, again, just like, the first trial I discussed here, they picked moderate to severe functional MR. So EROA was 0.25, as you know, by definition, it's 0.4. And if we look at co-opt and MITRA FR, co-opt selected all the patients with 0.4. And I think MITRA FR, the mean was around 0.3. So, a bit different, so a bit lower, moderate to severe MR rather than the severe MR. And otherwise, I think the patient population was similar, except ReShape HF has less sick people, so less risky patients, because they had better BNP, they had better, kidney function. We know that MITRA FR patients had lot of LV dilatation, and co-op, they had more MR, but not that much of LV dilatation. So I think it's important to realize these differences between the trials so that we can understand what this trial can offer. And to me, it is very clear that one of the basic differences here, less sick patients, less MR compared to the other two trials. So I think similar to, co-opt, they had the follow-up set for 2 years. And then they had around 500 patients. They, again had patients with heart failure despite, good GDMT. They selected ejection fraction from 20 to 50%. Now, I think in this trial, only 9% had kind of EROA of 4, so less severe MR, more moderate to severe MR. And it showed that it showed that mitra clip can help with heart failure hospitalization, but didn't do much for the mortality. So again, you can one of the discussion points at the ESC was again why this conflicting results. And I would think that it's because MR is a very dynamic situation depending on where that patient is, on that particularly when you are screening. So of course they must have a core lab and they may have, tried to adjust for it, but this is also moderate to severe MR. And we know from imaging data that can be quite variable, even for core lab. So we know variability exists in imaging assessment, particularly if you are talking about moderate to severe MR. What you call 3+ or what you call 4+ can be very different depending on the operator. So I think that to me, it kind of reflects what we see in real life. And I personally wasn't surprised to see it did not do much for all-cause mortality endpoints. It did improve hospitalization. It did improve patients' quality of life. It did improve their 6-minute walk test. So, if we look at the limitations of this trial, I already told you that they took 8 years to publish, and we know in last 8 years, GDMT has evolved a lot. And again, this trial, after randomization, they don't have much information of what all medicines were changed, what was the optimal GDMT. You may call something optimal GDMT, but we all have lived clinically that life where patients are not able to tolerate GDMT because of their borderline blood pressure, etc. So I think, half of the year, I think Dr. Greg Stone was the discussant. And of course, I could see the enthusiasm in the audience, but I do think personally, being on the cautious side, that we really like this area still with MR being so dynamic. We don't know if moderate to severe MR or moderate MR, has an role, as far as the therapy is concerned. I think, again, like Matterhorn, in my opinion, at least, we have to ensure that our patients are on GDMT. And we have to ensure that they are fully medically treated. And of course, if they have symptoms, we have therapy. But otherwise, stay away and see how they are doing.
Yes, Purvi, thanks for, putting this trial, which, like you said, is the third trial now, trying to answer the same question in context for the audience, comparing the baseline characteristics with MITRA-FR and COAPT, and then sort of discussing what the findings were, which, like you said, the primary endpoint was primarily being driven by heart failure hospitalization, which, of course, the rates for recurrent hospitalization in patients with heart failure are abysmally high, still in all across the board in the US. And I think if there is any intervention which we can do as cardiologists, as interventionists, certainly would benefit our patients as well as our health systems. Regardless, I think it's device therapy and it comes with a cost. It sort of comes with, even though, I think in terms of safety, like we discussed, even with the first trial, MitraClip is a very safe device. Still, it's an invasive procedure. It comes with its procedure time, with procedural challenges, and I think we have to be mindful as to who we are sending for the device therapy. And so therefore it's crucial that we make sure, like you said, that patients are on maximally tolerated quadruple backbone guideline directed medical therapy for heart failure with reduced ejection fraction. Then we are doing due diligence in appropriately quantifying mitral regurgitation and calling it what it is, whether it's primary, whether it's secondary. And then, making sure that once we've exhausted all the options, that we are then referring these patients appropriately for device therapy if we think that they're going to benefit from it. So I think, I think it's hard to generalize this to all the patients with heart failure with reduced ejection fraction who have mitral regurgitation. So I think case by case basis, and making sure you're
advice. Yeah, I said that in this trial they actually revised the endpoint as well. So I think when they did like an interim analysis in 2018, they saw that the mortality was kind of lower than the other two trials, and then they had to extend the follow-up to kind of meet the criteria for that. So I think that in 2023, they extended the recruitment, and then they extended the follow-up, and then they had a separate primary endpoint. So I think, of course, I'm not I don't do statistics, and I don't do design for the trials. But as you know, like anytime anything is modified, particularly the primary endpoints, or like anything else, like who are the patients that are coming, that's not seen well in the academic world. So that was another criticism, that they had to modify to make sure that they were meeting the criteria for mortality, etc. And again, there was like it went for 8 years. COVID, I think it nearly stopped. So that that of course put that puts kind of limitation of like what these 8 years would look like, because we know that we have had a lot of data in this last 8 years, particularly with heart failure therapy. But yeah, no, I think I agree with you that we have to select these patients carefully, and it's always good to have data, and it's always good to know the sites of these trials, particularly the patient selection that happened. So I think that brings me to the tricuspid space. Should we discuss the TRIFR?
Yes, absolutely. Go for it.
Okay, so I think TRIFR kind of on the same theme. This was transcatheter edge-to-edge repair in treatment of severe isolated secondary TR. And so again, we have had a TriLuminate pivotal trial that showed that TriClip device, although it reduces the severity of TR and improves the quality of life, the mortality was not affected. And so we know that, and with that background, I think this trial was designed in Europe. We know that tricuspid regurgitation patients tend to be older, and even if you take like LVEF and pulmonary hypertension away, TR is not good for our patients. They suffer a lot. It limits their lifestyle because it's RV failure predominantly through TR. They're volume overloaded. It affects how much they can walk. It affects what they can do in daily routine. So I think personally, doing the TriClip, interventions, and from the echo side, when we see these patients in follow-up, it's amazing to see how even 1 grade of TR reduction, how much that can change for that patient with whatever lifespan they are left with. So I think it's important to gather more data in a different population, and I respect these researchers for that. So they selected, I think, around 300 patients. Mean age was around 78, symptomatic severe secondary TR, GDMT, and they were not eligible for surgery. And so this was comparison with GDMT versus GDMT plus Triclip. And then again, just like the previous trial, they ensured that, most of these patients, I think around 40% of these patients had been hospitalized for heart failure in the prior year. And then also, I think around 10 to 15%, I think 15% of them actually already had a implantable device in place. So, well-treated patient population. And the primary endpoint, it was like a composite of NYHA class, how the patient felt, what was their heart failure hospitalization, if they had any death because of cardiovascular risk, etc. So it was a composite endpoint. And to no surprise, of course, the procedure significantly reduced the severity of TR when they, when for the patients that, got the Triclip at 1 year compared to GDMT. And there was a difference in heart failure hospitalization. So only 35 patients out of those, that were selected had heart failure hospitalization, and mortality was low, but again, no difference in overall mortality, because we know that overall cardiovascular death in these patients may not be that common. So kind of similar outcomes as we saw with Triluminate. And I think it just is an informative trial. We now see that as we are, the good thing, the beauty of bringing the device therapy in mitral or tricuspid space is suddenly these patients have an option. And, I am just amazed since, these device therapies have started in heart failure, how many of patients we are able to benefit, right? Like how many patients come to Echo Lab, and now, we quantify the tricuspid regurgitation carefully, because we know that if it is truly severe, then there may be an option for them. So I think that these patients are out there in community, and we really have to give it to these researchers for having these options, just like the Triluminate trial. For having that Triclip device. Now, just like other trials, again, GDMT rates here were also lower, particularly if you look at the SGLT and MRA. So we can do better with that. But, whether it was because of side effects, whether it was other reasons, who knows? We have to do better with patient compliance. We have to engage with our patients and make sure that they understand how, this quadruple backbone, as you say, is really the backbone of, their therapy. The other thing, again, just like those MitraClip trials, the follow-up is short. 1 year is not enough, right? So we still are learning about the efficacy of these devices. And, even if this follow-up was there, I would say that real-world population, like as Triclip is becoming more and more common in cardiology community, where now we are not just restricted to center that do clinical trial and it's available commercially. We need to understand what that real world data would look like for residual TR in longer follow-up, so that we know how effective these therapies are in the real world. But till then, I do think that the data is very encouraging, and for our older patients that are are super limited by the symptoms. We are not able to do much daily routine because of this, severe TR, and because of the volume overload that comes with it. We have an option. We have an option for them. And again, as this data evolves, it will be so important to identify the patients that absolutely do not respond to this therapy versus the ones that do fantastic. So I think we still have a lot to learn. And to me, this it is a complex heterogeneous population, just like mitral valve. In Echo World, Ankur, we joke about it that, at least I think as an advanced imager and, someone who does these procedures in the cath lab with for Echo, I really thought that I was in love with mitral valve till I got to tricuspid valve. And, it's fascinating, what we are doing with device therapy, and really, really good time, to be in this space in cardiology, or whether it is advanced imaging or on the other side, on the interventional side.
Yes, exciting. I mean, for the longest time, we, at least I can remember now, come 2025, and I'll be 10 years out of my general cardiology fellowship. And in the last decade, the spurt in the structural heart space has been exponential, has skyrocketed. And I remember reading papers on tricuspid regurgitation 10 years ago, almost 10 years ago now, where this would still be considered the forgotten valve, and it's not the forgotten valve anymore. So it's incredible to see that within a span of a decade, the advancement has been exponential. And we now have a device which is commercially available, which our patients who were considered inoperable or at high risk for surgical repair or replacement now have an option. And that option is,
yeah.
And like you said, these patients, again, the listenership of Parallax and our colleagues in the community see these patients all the time. These patients are in our clinics. These patients are in the hospital wards. And, lo and behold, the echocardiography report says moderate to severe tricuspid regurgitation. And now, because you have therapy available, you're going to be more attuned to carefully quantifying and, making sure that you are putting these patients in the right bucket of severe TR, because that you have a device now which is safe and efficacious. So exciting times, and I think patient selection, careful diagnostic algorithms to diagnosing these patients properly, working collaboratively with heart failure colleagues and with imagers. I think it's sort of like rising tides is raising all ships, right? So you're working in unison with your colleagues, and you're basically helping these patients who were otherwise forgotten.
Yeah. And, to be honest with you, Ankur, I was thinking about, like, when was the time in cardiology before the structural space where we came like as subspecialty together on these topics, right? Like, apart from now it's like, because of these device therapy, everyone is so involved, and you just have to work as a team. So I think that to me is the beauty of the space, that, you rely on each other to do the best for the patients. And to me, that just shine, the teamwork shines, the collaboration shines, and the people that don't have it, they lose it, right? So I think it's really, really good when you get along with the team has to work, and team has to kind of speak the same language. And I think that's the beauty of kind of being in this space, being in these times. So I think that brings me to our next trial. This one, of course, is very special. So I selected the RIA trial, which is the transcatheter versus surgical AVR in women with severe AS. So I think this is the first trial that had TAVR and SAVR exclusively done in female patients. And a little bit of background on this trial, as we know, women have smaller aortic annula. And, we just earlier this year had a SMART trial analysis, subgroup analysis. SMART trial wasn't designed for women, but because it was targeting to the smaller annulus, I think 87% of the patients ended up being a woman. And, this was the expanding valve. That is the Medtronic valve. So they compared the hemodynamic data between the Medtronic versus the, Edwards Sapien 3 valve. And what it showed is basically early hemodynamics were better, with the self-expanding valve because of the supraannular design. It's so funny because when we look at this whole thing about structural deterioration on the TAVR valve, if you look at the VARC definitions, and the hemodynamic deterioration includes this whole business with like increased gradients, and that then translates into smaller EROA, and that's considered a structural deterioration. But I tell you, listening to structural heart echocardiographic legends like Dr. Becky Hahn, the jury is still out there what exactly all these gradients mean, particularly with TAVR valve, because we know that TAVR valve is essentially implanted like a stent in the big vessel like aorta. And we know that that turbulence can lead to high gradient. And why that question comes is because we know that if we look at the 5-year data with these high gradients, the outcomes weren't affected. But nonetheless, that's the story with smaller annuli. That's the story with, PPM. That is really actually right now is the trending topic in the echocardiographic structural world, because there are these two designs of the TAVR valve, the Medtronic valve that is self-expanding, supraannular design. And by design, it leads to less gradients versus the Sapien valve, which is annular, as you know, and then has been associated with high gradient. But nonetheless, I think this was, the RIA was done in all the European countries. I think it was started in 2019 and finished last year. It had 443 women. Mean age of 73, low STS score, symptomatic severe AS, and they were randomized to either Sapien 3 or Sapien 3 Ultra or SAVR. And then SAVR wasn't like one SAVR. They basically chose whatever SAVR that they had available. I don't know how they chose it, but 215 patients got TAVR, 205 got SAVR. 1 year follow-up was available almost with 97% of the patients. And again, as we know, these patients are all women. 2/3 of the patients, of course, had smaller annuli, and that is annular size of less than 430 millimeters square. So baseline character were almost same. There was some more peripheral arterial disease. In the SAVR group, mean gradient was 47, EF normal, more than 60% for both the population. So of course, as we know, we understand the TAVR data much better, and this was kind of parallel to that. Nothing different in women. TAVR patients did have shorter hospital stay. They were discharged early to home. They had less, AFib. They had quick recovery because, of course, it's a transcatheter procedure. And but just as we know with the Sapien valves, there was higher incident of, PVL and PPM. I must say, as we know with TAVR valve, not the Sapien valve. So primary endpoint was, again, composite of all-cause mortality, stroke, rehospitalization, for any procedural related symptoms or like heart failure at 1 year, which was 8%, around 8% in TAVR group, 15% in SAVR group. Basically the differences met the superiority criteria. And mainly if we look at, because it was a composite endpoint, you have to kind of dive deep what was driving it. And it was rehospitalization. So all-cause mortality and strokes were kind of similar. And then we know that, patients that get surgery have more AFib. So of course, TAVR patients had less AFib. But then SAVR had less pacemaker. So kind of similar to what we have known. Now, why I mentioned all those things about the hemodynamics and gradient is because when we look at the echocardiographic data here, the mean gradient at baseline, as I told you, it was like 47 in both the group. But if we look at the TAVR versus SAVR, there was some difference, and it was significant. So at 1 year in TAVR group, the mean gradient was 14, and in SAVR group it was 11. And then similarly, if we look at kind of that trend overall, even at 1 year, it remained, right? So I think that it comes up because these patients had smaller annuli. And then the next question you may ask is, because they had smaller annuli, they got SAVR. So the SAVR arm, how many of them actually had root enlargement? And, I think it was less than 50% of the patient had root enlargement. So although more than 80 had smaller annuli, less than 50%, I think around 45% had root enlargement, and they all got like 19 mm or 21 mm AVR, which was not uniform, any AVR that they got. So I think we had to ask our questions that, why all these smaller annuli patients did not get the aortic root enlargement. And the funny thing is, in spite of not getting the root enlargement, when you look at, the gradient and the, by definition, severe PPM, it was higher in the TAVR group. So the overall echocardiographic data was, if you look at it, it looked more favorable to SAVR in spite of not having root enlargement. So I think that's why I started giving you that background of this whole thing with gradients with TAVR valve. And I think some experts do really think that it is nothing but turbulence that we are measuring rather than gradient, and PPM with TAVR valve is extremely rare. But I think our trials are still using the same criteria. So, how to interpret this data in context of all those, all that confusion that I just told you about is difficult. But nonetheless, we know that our female patients have, better outcomes, not just non-inferior, but superior outcomes, with TAVR. So that's always a good option to have.
Yes, I think first sort of transcatheter heart valve trial exclusively in women, and addresses a crucial clinical scenario of small annuli, which when we have our TAVR meetings every week, is something we commonly discuss. Root enlargement versus offering them a TAVR valve if it's a smaller perimeter or a smaller annular area, and tend to go with the self-expanding valve because of the supraannular design, like you mentioned, compared with the intraannular design of the balloon expandable valve. Now that we have this trial, Purvi, is that something you think will become, at least in your institutional practice or in your clinical practice or in the practice of your interventional colleagues, you think is going to become, or surgical colleagues, is going to become the modality of choice for replacing the aortic valve? Now, we just did this paper in JAHA where, we looked at the Medicare data, and in comparison with 2012 and 2019, more patients are getting transcatheter heart valve compared with the surgical valve, but that's also because with the advent of transcatheter heart valve, we've increased the number of patients we're treating now with aortic stenosis. So with this particular trial, do you think women will exclusively start getting referred for TAVR and not considered for surgery, or do you think it's still going to be individualized, based on anatomy and other risk factors, underlying conduction disease, taking into account pacemaker, shared decision making? What do you think?
I don't think it's going to change any of the practice that we are practicing right now. I think why data is important is because, of course, you always had that question with smaller annuli, can you do TAVR, and what exactly it's going to look like for these patients for longer follow-up. Like, of course, this data is at 1 year, but we'll see what the 5-year or the 10-year data may look like. But I think that's the main thing, right? Like, women come with smaller annuli, and before we didn't have, although SMART trial subgroup kind of showed us that smaller annuli data. I think, as I said, it was with it was Medtronic versus Sapien. So this comparison is kind of nice to see that, not only we were non-inferior to SAVR, but we were, superior. But I don't think, to be honest with you, that would change much if I have a patient that is youngish, and, I has a smaller annuli, and it's a BSA very small, and they come to me with severe AS. I think, again, the first step is shared decision making with a patient and figuring out what exactly they would like, meeting them what they want, telling them about both the sites, which I think it's good to have data, because now you can inform your patient even on the TAVR side and comparison of TAVR versus SAVR, and then letting them choose. And if that patient still would choose SAVR, and then surgeon is giving me an option of root enlargement, I do still think that might be a that's how I would practice, and that's how we practice here. But again, if that same patient comes and is a bit older, and or even the same age group, and wishes for TAVR valve, absolutely I would give them TAVR valve, because this trial does give me that comfort. The STS score was not a very high here. This whole gradient business does bother me, right? Because I think we do get, when we see the difference of 10 mm mercury, at 1 year, and then 2 year and 5 years, we do. I mean, as a clinician, you do act on it. You just don't say that, okay, this is just turbulence, I'm gonna ignore. You do CT. You want to make sure that there is no thrombus. So I do think that it's still kind of interesting to see how this space is going to evolve and what more data is going to show us. We know that there has been conflicting results with the supraannular and annular long-term studies. So I do think that it still kind of bothers me. So I would just go to the patient and kind of, have that shared decision making, see the procedural characteristic, discuss it with my interventional colleagues, structural colleagues, and see what is the best outcome possible for that particular patient that I'm seeing in clinic. So I would say that it won't change my practice, but for the patients, it's important to have data so that we now have that information that we can discuss with our female patients, which always, has been the percentage of recruitment of women patients has been low in the prior trials.
Yes, no, I mean, it's to have an all-comers women's trial in transcatheter heart valve interventions is phenomenal. So, certainly congratulations to the investigators in making that happen. And, again, an important addition to the literature, like you said. So moving on, the final trial that you're going to discuss for us for this episode is another important one, is similar in vernacular to the one that you just discussed, but this is called Seniorita. Do you want to talk to us about this one?
Yeah. So Seniorita, tested invasive versus conservative GDMT strategy for older patients that came with myocardial infarction. I think the background for this is, of course, for the older patients like that are 70 years and older. What is the optimal treatment? Is it truly, particularly when they come with NSTEMI and not STEMI, is it like truly PCI versus, are we like, not doing PCI? So, the data suggests that we actually, these patients are PCI is underutilized. So this was, kind of selected on these elderly NSTEMI patients. And, I think there are some small studies that are out there in this space. But they're all smaller. And this was a huge trial, I think 1,500 patient. And, why I selected this trial is because, as you know, I practice in blue zone. These are my patients that I see on a daily basis. So I think it really, the design as well as the results, were to me were very applicable, and I was drawn towards like diving deep into it. So the mean age for these patients, 82 years again, and Vijay Kundian was the PI, 45% women. So I think that is fantastic, and they selected invasive therapy versus just the medical therapy with aspirin, up-E2Y12 antagonist, statin, beta blocker, ACE inhibitor, or ARB, they managed. I think 90% of the patients had in the invasive arm had cardiac catheterization, and around 50% had PCI. They just selected patients as they came. Recruitment for them was difficult, which I think we can imagine because these are older patients. In fact, you won't believe the oldest randomized patient in this trial was more than 100 years old. So it was 103 years old. So very much like blue zone population. And a lot of them, I think 33% of them were frail. And almost more than 50% of them had, cognitive dysfunction. So they did a very good frailty assessment. They did cognitive assessment. And then, we have all seen these patients. And when we see the patients, we see they're frail. They have, dementia. That alters our clinical decision making, and we may go for medical therapy depending on how the patient is looking, right? So I think a very, very applicable question for these older patients. They had, I think, 4-year follow-up, and they tested, the primary endpoint was cardiovascular death or non-fatal MI, which I think was non-significant in both the arms. But if you look at the non-fatal MI, that was, of course, less with PCI arm, as we have seen with other trials as well in the interventional space. But overall, no differences, just like other trials in this space previously had shown. I think the revascularization in the follow-up was also reduced when they did the PCI, as you can imagine. So conservative arm had more follow-up revascularization, but otherwise there was no other difference with bleeding and stroke, etc. So I think, again, when you bring up this discussion with our patients that are in this age group, I think, again, it's good to have this data that you have reduction in myocardial infarction, you have reduction in follow-up, PCI, subsequent PCI, but then, not that of a signal, not that of mortality benefit. So to me, I think, again, it's important to have this data so that we can, again, have the shared decision making, for our patients. I think the other thing that I like to point out is, particularly taking care of these blue zone population, what I've realized, the way we quantify NSTEMI, right? Like what is NSTEMI? What exactly that troponin leak and where it is coming from? It's so important to establish. And again, imaging can come really handy because we know with high sensitivity troponin, we are going to detect troponin, and these patients, they are older, they have other comorbidities, and troponin leak particularly would not be that uncommon. So again, we come back to careful selection of who are going to be these true NSTEMIs, where you're not seeing any other reasons for them to have these troponin leak, carefully selecting them and treating them, giving them the information that they need, having that shared decision making, I think is beneficial. So I think, to me, this data adds up to the present knowledge we have for these patients. And, it's important to have that information for our patients, because I tell you, Ankur, some of my patients, they are, they may look 100, but they're living a life of 70 years old. So it's important to not take age as a number, but rather treat the patient that's in front of you and, the life they are living, so that we can ensure quality of life even after the event, myocardial infarction has occurred.
Yes, no, all excellent points. As a matter of fact, I had a patient I just spoke with today, citing the findings of this particular trial. And, couldn't agree with you more. Troponin has become the fifth vital sign, as I call it. It's ubiquitous. The troponin leak is ubiquitous. I think, did I see this paper this week or maybe last week? There was a paper out in JACC journals where they were proposing an upfront strategy for selecting revascularization for NSTEMI based on the findings of CMR, which I know you're an expert in.
Yes. Yes. In fact, I retweeted that paper. And this is why I, kind of mentioned that point that I was telling you, that imaging really can come handy when we are trying to select out of this very heterogeneous group and living in the high sensitivity troponin era, to figure out who are these patients that can truly benefit, particularly when they are elderly. They may have, cognitive dysfunction. They may be frail to start with. Who are the patients that you're going to expose to PCI? Not that PCI is unsafe. It's a simple procedure that can be done. But I think it's good to have that imaging data to support you. Absolutely.
Yes, and I think PCI has of course evolved into being an outpatient safe procedure for the most part. Now, given that you're dealing with a frail patient population with extremes of ages, some of these lesions and some of these lesion subsets are going to be high risk. Some of them will require plaque debulking or plaque modification with atherectomy, and then certainly surgeons are not keen on taking these patients should complications occur. So I think again, having a shared decision making approach, making sure that you are weighing all your options should complications occur, and having that discussion up front with the patient that, look, medical therapy, conservative strategy with optimal medical therapy was not inferior, like you said, when it comes to mortality, I think is an important adjunct to the decision making, and then certainly let the patient decide. So again, very informative trial. 45% were women, so great job in enrolling women there. So the findings were published in the New England Journal of Medicine. So Purvi, thank you. This has been a fascinating discussion, great discussion. Very important topics, sort of bread and butter of modern 2024, 2025 cardiology. Do you have any closing remarks for Parallax, for our listeners? And maybe we could do a second segment to this, because I know that there were more important trials which were presented at ESC.
Yeah, no, absolutely. I would love to cover them because, as you know, at the end of the day, we are all general cardiologists and we are taking care of, more other issues that are not severe MR and severe TR. So let's find some time to discuss them. And there would be a part 2 soon, hopefully. But I think, closing thoughts really, like what exciting time we are living in, right? Like where teamwork, is the forefront of providing that cardiovascular care to our patients. Collaboration is at the forefront. We have all these tools that we can offer to our patients. So to me, just very grateful to be, practicing as a cardiologist. Thanks to all the scientists and researchers that do all this work for us. And keep us on our toes with evolving literature. It truly is an exciting field to be in, and I'm sure you feel the same way. So I think we are all I feel like we all have kind of similar personality when we come to cardiology, and I feel like this field keeps fueling that vigor and passion we have for taking care of our patients.
Yeah, I couldn't agree with you more. It's very gratifying. It's very fulfilling. One of the most evidence-based fields in all of medicine, let alone internal medicine subspecialties, I think across the board in all of medicine, I think is one of the most progressive and most evidence-based fields, and a lot of patients, a lot of data, and always on the cusp of something new and exciting that we can offer to our patients. So no, Purvi, thanks again. I know this has been an effort on your part to get this done. You've had a busy day in clinic. So thank you for doing this at the end of your busy day. And until then, hopefully a second, part 2 to this. Thanks for listening. Thanks for tuning in to our listeners. Thanks for keeping us afloat for all these years. This is season 6 of Parallax. We take your feedback seriously. So do share your feedback with us, rate us, review us on Apple Podcasts, SoundCloud, and Spotify. And until next Monday, or other Monday, I should say, thanks for tuning in.
We hope you enjoyed today's podcast, produced by Radcliffe Cardiology in association with makeadent.org. We aim to bring you a new angle of all things cardiology every second week. Review us on your favourite podcast app, or send your comments or questions to podcast@radcliffe-group.com. To view the series, head to radcliffecardiology.com/podcasts/Parallax. Thanks for listening.